Our speaker is a graduate of the School of Medicine at DLSU College of Medicine. Took her internal medicine residency training at Medical Manila Center. Took her pulmonary fellowship training at Manila Doctors Hospital. She is a diplomate and fellow of Phil College of Physicians. A diplomate and fellow of Phil College of Chest Physicians. Let us all welcome Dr. Cynthia R. Talla.
Good afternoon. First of all, I would like to congratulate PCOM on their 4th postgraduate course and thank the scientific committee for having me. The title of my talk this afternoon is Air Quality and Ventilation, a Threat to the Respiratory System, the Clinical Perspective. This is the outline of my talk. So we will try to review COVID-19 transmission and how it affects the workplace, and then revisit the latest guidance on workplace prevention and control of COVID-19, zeroing in on engineering and ventilation strategies. I will leave the engineering details to our engineer speaker who will talk about that this afternoon. And lastly, I was requested to talk a little about long COVID, and I came up with a clinical practice guidelines in primary care that was published in 2021. COVID has been with us for 2 years, and we all know that it is caused by SARS-CoV-2. It's a coronavirus that is a single-stranded RNA that is so small, and it has a crown-like appearance because of the spike glycoproteins. We also know at this time that it is highly infectious, it is highly transmissible, and it can be spread even by individuals who have no symptoms. It can be spread from person to person. If you have a close contact with someone who is sick, and especially so if you are within a meter from that person, then you get the likelihood of being infected. The droplets that are released when someone with COVID-19 sneezes, coughs, speaks, can also land in your mouth or nose. And then it can spread easily in poorly ventilated and crowded indoor settings, where people tend to spend long periods of time. This is because the aerosols remain suspended in the air or can travel farther than a meter. It cannot only spread from person to person, but it can also be contracted by the virus that is left in the objects and surfaces. But it is not the major transmission. Not everyone gets COVID, but there is a specific at-risk population who can have the severe illness. And these are the elderly people, those with pre-existing medical conditions like diabetes, heart or lung disease, asthmatics, even smokers, pregnant women, and those who are immunocompromised, like let's say people with cancer who are undergoing chemotherapy, those infected with HIV, those who have immunodeficient states, and those taking steroids. And we will include here already the individuals who are not vaccinated. At the national level, this strategy is central to the National Action Plan to contain the infection and return towards the new normal. On the other hand, this is the minimum public health standards mandated by the government, which we all follow at this present time. The last layer of approach to prevent the spread of COVID-19 is vaccination. We all know that it works from the data that we have on the effectiveness of the vaccine in preventing severe illness and death from the disease may be something like 84 to 87%. Hence, we continue to encourage our employers and employees and their relatives to be vaccinated with primary series and the boosters. With the bigger population of the community having been vaccinated, the protocol for quarantine and isolation has changed and has different recommendations for fully vaccinated or partially or unvaccinated contacts and for the general public versus the healthcare workers. So for those who are asymptomatic close contact but fully vaccinated, okay, For the general public, the recommendation for the quarantine is for at least 5 days from exposure. No? For healthcare workers, it must be at least 5 days from the exposure, or maybe shortened up to 0 days if boosted. Okay. For the partially vaccinated or unvaccinated, it must be at least 14 days from exposure for the general public, and the same for the healthcare worker. Now, for the isolation, okay, these are the patients who are maybe asymptomatic, but if they are fully vaccinated, for the general population, at least 7 days from a positive result. For healthcare workers, it must be at least 7 days from positive, but may be shortened up to 5 days if boosted. Okay. For the partial unvaccinated or unvaccinated, for the general public, it must be 10 days, and 10 days also from the positive test for the healthcare worker. Now, for the symptomatic cases with mild symptoms, or those who are suspected or probable where there wasn't any testing done, no? For the fully vaccinated and for the healthcare worker, it must be at least 7 days from the onset of symptoms. Again, for the healthcare worker, if they are boosted, may be shortened up to 5 days. For the partially vaccinated or unvaccinated, both for the general population and the healthcare worker, at least 10 days from the onset of symptoms. For those who have moderate symptoms, no, regardless of the vaccination, both for the general population and for the healthcare workers, it must be at least 10 days from the onset of symptoms. For those with severe and critical symptoms, again, regardless of the vaccination, it must be at least 21 days from the onset of symptoms, both for the general population and the healthcare worker. And lastly, for the immunocompromised, regardless again of the vaccination status, both for the general population and for the healthcare worker, it must be at least 21 days from the onset of symptoms, but with negative repeat RT-PCR. Now, let us try to define air quality, okay? So it is defined as the condition of the air within our surroundings, and it can be indoor or outdoor. Indoor air quality may be polluted by cigarette smoke, molds, dust, pet danders, okay? VOC, radon gas, formaldehyde. It can be clear and unpolluted, but it can also be polluted, no? Both by natural and man-made pollutants, no? So for the natural pollution, it may be volcanic eruptions or windstorm dust, but man-made may be coming from vehicles, toxic gases from industries, coal-powered plants, burning wood, and landfills. On the other hand, ventilation is defined as the process of bringing fresh outdoor air inside and letting indoor air outside in order to maintain or improve air quality. The risk of getting COVID-19 infection is increased in crowded and poorly ventilated settings. Okay, this is because the virus actually passes between people through infected respiratory particles in the form of droplets and aerosols. No? In poorly ventilated spaces, the infected aerosols can remain suspended in the air or can travel farther than conversational distance. So, improving indoor ventilation reduces the risk of the virus spreading indoors. Traditionally, this is the hierarchy of hazard control that has been used as a means of determining how to implement feasible and effective control solutions. It is a system used in industry to minimize or eliminate exposure to hazards and is promoted as a standard of practice in the workplace. Here, as you can see, the most effective is at the top of the inverted pyramid, where elimination is the most effective. That is, we physically remove the hazard. No? That is followed by substitution. You replace the hazard, and then the engineering controls. This time you isolate the people from the hazard, and then followed by the administrative controls, where we change the way people work, and the least effective of all, is the PPE, where you protect the worker with the personal protective equipment. Among the engineering control strategies, these are strategies that are designed to protect the workers from hazardous conditions by placing a barrier between the worker and the hazard, or by removing a hazardous substance through air ventilation. You thus involve a physical change in the workplace itself. It is preferred over administrative and PPE because they are designed to remove the hazard at the source before it even comes in contact with the worker. It is highly effective in protecting workers and is independent of worker interactions, but the cost of control is high. There are several strategies that have been done since the start of the pandemic. So this includes actually installing physical barriers like the sneeze guards and the acrylic barriers that we have seen around, which we also use in our clinics before. The use of air purifiers have been suggested, and HEPA filters. We also have to ensure physical distancing, especially in areas where a flock of people may be seen, like in waiting areas, elevators, in cafeteria. Increasing the ventilation rates to reduce the concentration of the viral particles in indoor air and limit the spread of COVID-19 is a must, okay, in engineering controls. So this is where the role of the HVAC systems comes in, with one-way flow of the air must be followed. This is the directional airflow, where air flows from a clean to a lesser clean air. Okay. There are also exhaust systems or fans that are installed in restrooms, especially in restrooms and kitchens. And the use of fans are also advocated, although there is a caution against the flow of air in the use of fans. Opening the windows and doors have also been implemented. Now, to illustrate that point, again, keeping in mind that the virus that causes COVID-19 spreads easily in indoor and poorly ventilated settings. So again, the definition of ventilation is to bring fresh outdoor air inside and letting the indoor air outside. So good ventilation is actually just done by opening a window. A better ventilation may be obtained or achieved if we open the windows and doors on opposite sides of the room to create cross ventilation. Okay, if you only have one window, you have to put the fan with the head of the fan facing outside the window. Okay, so that we bring indoor air out and let the outdoor air in. When it's too hot or cold, you leave the windows open for a few minutes each hour to bring in fresh air. When we use a fan, okay, you always open the windows and doors. Okay, so running a fan in a closed space can increase the spread of the virus. Now, if we have an air conditioner, using a wall or window aircon, please be reminded you have to open the windows for a few minutes every hour. Most wall and window air conditioners increase the spread of the virus by recirculating indoor air. Now, in centralized air conditioning, the setting must be set that will increase the amount of outdoor air that will be pulled into the system. Make sure that the system is regularly inspected, maintained, and cleaned, usually on a weekly basis. When using an air filter, on the other hand, be reminded that air filters do not replace ventilation, but they can help reduce the possibility of transmission. And continuing to open windows for a few minutes every hour to bring in fresh air will be of big help. Now, in cars, when you use your air conditions, use the setting that brings in fresh air. Settings that circulate the inside air can increase the spread of the virus. These are just examples of the engineering strategies that we discussed earlier. This is the HVAC system, and these are the HEPA filters. Now, especially in hospitals now where aerosol generating procedures are being done, now we need to have a specialized negative pressure rooms for these procedures, okay, where we force air out coming from the infected room. What about restrooms and water closets? No? So we have to make sure that exhaust fans are functional and operational at full capacity. You have to close the toilet bowl lid before flushing, and we don't encourage the use of hand blowers and jet dryers. Now, there are other engineering control strategies, like the installation of hand hygiene and sanitation facilities. We have to create a separate entry and exit point, especially in high traffic areas, no? Like you can have sectioning, signages for queuing, and establishment of screening and triage area at different points of entry. Okay, there should be visual cues or signages to communicate this to the public, and the facility for proper storage, collection, treatment, and disposal, especially if they use PPEs and other infectious wastes. Now, for the storage, no, there should be a designated storage bins. No, the yellow ones that we use is for the infectious wastes. No, and that is actually where we also put our PPEs. No? So for the collection, treatment, and disposal of the PPE, the personnel who is assigned to do this should be wearing a medical grade mask, no, and puncture-proof gloves aside from PPE and face masks before the final disposal. Now, what about for smokers? There should be a designated smoke areas. And again, in these areas, there should be strictly physical distancing, and there should be health protocols that should be placed, no? Like there should be no talking inside these designated smoking areas. Even in shuttle areas, no, it is suggested that the window should be at least 3 inches from the opening, okay? And there should be also physical distancing and wearing of face masks. If you are in a public space and you cannot even open the window and you don't know whether the space is well ventilated, then spend as little time in that space as possible. You have to maintain physical distancing of at least 1 meter, wear a mask, and then clean your hands and get vaccinated as soon as you can. There are other non-medical interventions that are no longer recommended at this time. So initially, during the pandemic, there were suggestions of air filters, foot baths, disinfection tents, misting chambers, sanitation booths, even the use of UV lamps, no, and even these barriers, no, which we now don't use anymore. Now let's try to shift to long COVID. Okay, it's something that I was requested to talk on, and we start with the definition. Okay, it has actually a lot of names. It also is known as post-COVID condition, post-acute COVID-19, post-acute sequelae of SARS-CoV-2 infection or the PASC, chronic COVID, or long-haul COVID. It is actually an umbrella term for the wide range of physical and mental health consequences experienced by some patients that are present 4 or more weeks after the SARS-CoV-2 infection, including the patients who had just initially mild or even asymptomatic infection. How common is long COVID? So this is a meta-analysis done by Chen et al. And was published earlier this year. And the global prevalence is around 43%. Here they saw also that the longer the patient stayed in the hospital, around 120 days has a higher prevalence compared with those who stayed only for 30 days. The prevalence is also higher for those who were hospitalized compared with the non-hospitalized. For females, and regional Asia has more prevalent long COVID than Europe and Asia and USA. Now, here in this study, long COVID is actually defined as having the infection during the first 4 weeks. Okay. Post-COVID encompasses the infection that persists 4 weeks or more, but subacute or ongoing COVID is that lasts from week 4 to week 12. And then after week 12 is already post-COVID-19. In this meta-analysis of 2021, they found out that the most common symptom of long COVID is fatigue, headache, attention disorder, dyspnea, and even ageusia. We all know that long COVID actually involves multi-system, and all of these symptoms may persist for a longer period of time. 80% of these COVID-infected patients may have at least more than one symptom. Again, in that study by Chen, they found out that fatigue is the most common symptom of long COVID patients, followed by memory problems. This came from National Institute for Health and Care Excellence. We have to note that recovery time actually is different for everyone, but for most people, symptoms will resolve by 12 weeks. The likelihood of developing ongoing symptomatic COVID-19 or the post-COVID-19 syndrome is actually not linked to the severity of their acute COVID-19. Meaning, even if you have a mild disease or even if you are asymptomatic, you may still experience long COVID symptoms. If new or ongoing symptoms occur, they can fluctuate, affecting them in different ways at different times. I have come across this clinical practice guideline that was proposed by Catalan family med and community med physicians. So it was published in 2021, and we hope that we can discuss this in detail today. Okay. So let's actually start it by defining what acute COVID-19 is. Okay, so here they defined it as the signs and symptoms of COVID-19 for up to 4 weeks. The ongoing symptomatic COVID-19 is when a patient has signs and symptoms of COVID-19 from 4 weeks to 12 weeks. That is not explained by any alternative diagnosis. And post-COVID-19 syndrome is the signs and symptoms that develop during or following an infection consistent with COVID-19 that continue for 12 weeks or more and are not explained by any alternative diagnosis. So this group of doctors actually created a working group that consisted of primary care physicians, so 90% of them, but they also have internists and ID specialists and epidemiologists and statisticians. They focus on patients that did not require hospitalization and whose diagnosis and follow-up has been made in primary care. And what did they do? They used published studies, editorials, expert opinions, press releases, and clinical experience and systematic search of PubMed database until January 2021. So how did they go about it? So there was a planning of care for patients with long COVID, and this was done by 3 visits, okay? During visit 1, they did complete history, PE, and complementary tests. And actually, visit 1 is made from 4th week after the confirmation of the diagnosis of COVID-19. And preferably, it must be done between 5th to the 6th week. The visit should last only for around 30 minutes, and medical records may be of help because that may be the time when you get to have information that may explain the signs and symptoms of that patient. Okay. As far as COVID-2 infection is concerned, you have to know the date the test was done, whether this patient was hospitalized, whether they required O2, ICU admission, the therapies they received, the complications, and the date that they were discharged from the hospital. Of course, PE must be complete. There should be complete vital signs, baseline SpO2, and there's examination of the oropharynx and the cardiopulmonary system. And of course, labs will be done by this time. So again, on visit 1, these are the things that we need to do. Visit 2 is made from week 8, preferably week 9 or 10. And the objective of that visit is for us to evaluate the results of the tests that were done on visit 1. Okay. Here we also make a differential diagnosis. Okay. So when the patient comes in again with the symptoms, we have to make our differential diagnosis with other post-COVID-19 situations and apply the diagnostic algorithm to identify possible causes that reasonably explain the symptoms. And on visit 3, which is made from week 12, preferably between week 13 and 14. And the objective here is to evaluate the evolution or the persistence of the symptoms, of the long-term symptoms, and reevaluate possible causes, again, using the corresponding diagnostic algorithm. So this is how it looks like, okay? Fatigue, as we have said earlier, is one of the most common extra respiratory symptoms of acute COVID-19, which is maybe present in 41% of patients. Okay? So here on the first visit, okay, the first thing that we need to do is ask if there are previous illnesses the patient has, okay? Because if you say yes to all of this, that patient may have previous problems that may explain the current signs and symptoms. And we may be dealing with a relapse or an exacerbation of a previous illness, okay? If none, then this may be related to the severe COVID infection, and ask especially if there is involvement of the lungs, the heart, and the kidneys. Again, if there is, this may be a sequelae of the COVID-19. If there is none, or this is not related to the severe COVID, then at the time you have to do some tests. The tests that are recommended actually for fatigue are this, okay? You need to do hemogram or CBC, ESR, D-dimer, electrolytes, liver, renal, thyroid function profiles, protonogram, and even serum cortisol. For the labs, you have to get oxygen saturation, ECG, of course, X-ray, and maybe spirometry. Now going back to the algorithm, so once you have done those tests, we go to visit 2. Again, in visit 2, the objective is for us to do some other differential diagnosis that will explain whether this is not related at all to COVID. So again, if you have done your differential diagnosis and you have already identified what may be the possible cause, then this may be an unrelated COVID-19 etiology. If none, we now have an unexplained ongoing fatigue. And now the visit 3 will come in, which may be on the 12th week. Now at this time, we have to rule out chronic fatigue syndrome. And these are some of the criteria that we need to fulfill. So you have to ask the patients this information. And if you have less than 4 features, then that patient may have an unexplained post-COVID-19 fatigue, and they must be followed up in the primary care and evaluate them for rehabilitation or psychological care. Now, if you have 4 or more features, okay, you reevaluate them at 6 months, and if there is persistence of the fatigue, then you might have to refer them to the specialty clinic. To them, they have the chronic fatigue syndrome clinic. And here we might have to refer to our specialists. Now let's try to go to arthralgia. Okay. Patients with acute SARS-CoV-2 may develop arthralgia in around 7-8% of the patients. No? And this may be non-arthritic joint pains, no, without inflammation, without edema, without joint pains, or heat. No? So it may be difficult to locate muscle pains. No? But again, here, the first thing that you need to do is ask whether the patient suffered from a previous illness. And if yes, this may just be a relapse or an exacerbation. If not, then we do some other tests. Again, let's go back to the test that needs to be done for arthralgia. So these are all the tests. And these are all the other diagnostic tests that are recommended. Now, after having done those tests, the patient now follows up. Visit 2. If there is persistence of joint inflammation, then this may be post-COVID-19 arthritis. Again, if none, we have to do our differential diagnosis, and we might be dealing again with an unrelated COVID-19 source. If not, then we have an unexplained ongoing arthralgia, and follow up these patients on the 3rd month, no? Which is on the 12th week actually. Okay, we have to rule out fibromyalgia, and we have to ask these patients the pain scale. If the score is less than 4, you have an unexplained post-COVID-19 arthralgia, and these patients are asked to follow up in the primary care and again evaluate for rehabilitation and psychological care. If you have 5 or more score in the pain scale, then you might have to refer to, again, the specialty clinic. Let's try to go to myalgia. No? It may affect more than one or more muscles, no? But usually this is benign and self-limiting. Okay, so again, we have to ask for previous illnesses, because this again may be a relapse or an exacerbation of that illness. And then we have to do some tests during visit 1 for myalgia. These are the tests that we need to do. These are the diagnostic tests that is suggested. Then the patient goes to visit 2. Again, here, the objective is for us to do differential diagnosis and look for other causes of the myalgia. No? Like we may be dealing again with post-COVID-19 myositis or unrelated COVID-19 etiologies. If there are none, then we have now an unexplained ongoing myalgia. And again, the first thing to do is to rule out fibromyalgia by asking again the pain scale. Again, if it's less than 4, then this might be followed out by the primary care, evaluate again for rehabilitation and psychological care. If you have 5 or more, then this may be a fibromyalgia associated with COVID-19, and a referral to fibromyalgia unit or to other specialists may be done. For chest pain, which may be actually around 13%, no, for those having acute infection. However, the first thing that we need to do on follow-up in the clinic is look for red flag symptoms. Is there breathlessness, syncope, hypotension, severe hypertension, tachycardia or brady, agitation, and reduced consciousness, because we might have to refer these patients to the emergency room. If there are none, again, we look for previous illnesses. No? So history is very important, and see whether, again, we are dealing with a relapse or an exacerbation of previous illness. If none, this may be severe COVID-19 related and may be a sequelae. Okay, these are the things that we need to know in the evaluation of severe COVID-19, whether there are lung involvement, pleural, myocarditis, pericardial effusion, or iatrogens. If there are none, these patients will be going into visit 2. Again, we have to do differential diagnosis, okay? We have to rule out rib fractures, muscular strain, or unrelated COVID-19 etiologies before we can say that this patient has unexplained ongoing chest pain. And then on visit 3, when you have a persistent chest pain, then this is an unexplained COVID-19 chest pain, and we might have to refer to an ENT or a pulmonologist. For chest pain, these are the recommended tests that we need to do. And for the other diagnosis tests, these are the ones that we need to do. Now let's try to go to cough. Cough actually occurs in about 80% of acute SARS-CoV-2. No? While long-term cough has been reported actually in around 33 to 43% of cases. Those that will persist on the third week may only be at around 17%. But just the same, on the first visit, we have to know whether there are red flags. You ask for hemoptysis, hoarseness, significant sputum production, systemic symptoms, complicated gastroesophageal reflux disease, choking or vomiting, recurrent pneumonia, and pathologic X-ray. And we have to ask these patients to go to the ER. If none, ask for previous illnesses, no? And then we might be dealing with a relapse or an exacerbation. If none, then let's ask about the COVID-19 severity and the involvement. This might be a sequelae of the infection. If none, the patient will go now to the second week of the visit, and then here again we look at the other differential diagnosis that may explain the symptoms of the patient, and it might be an unrelated COVID-19 etiology. If that will persist, you now have an unexplained ongoing cough. Persisting beyond 12 weeks, we might have to refer to a pulmonologist. Okay, for cough, again, these are the tests that need to be done. And these are the other diagnostic tests. For dyspnea, or the feeling of breathlessness, no, or difficulty in breathing, may actually sometimes be confused with fatigue. Okay, but again, when the patient comes to us, the first thing is to look for red flags. Is there reduced consciousness, agitation, bad tissue perfusion, difficulty in speaking, cyanosis, respiratory work of breathing is high, tachypnea, low SpO2, and silent chest, no? And then we have to ask these patients to go to the ER. If none, ask for previous illnesses, and you might be dealing with a relapse in exacerbation. And then again, if none, let's try to look at the severity of the COVID, looking specifically at this involvement, okay? And this might be a sequelae of the COVID-19. If none, at visit 2, we still need to do other differential diagnosis to explain the dyspnea, because this might be a post-COVID-19 complication. And if none, then we go to visit 3. That's an ongoing dyspnea. And again, these patients are asked to follow up in primary care in an eventual referral to an ENT or a pulmonologist. For dyspnea, these are the tests that we need to do and the other diagnostic tests. Now for anosmia, again, these are the things that we need to ask for previous illnesses, for relapse and exacerbation. For visit 2, we have to do differential diagnosis that may explain the anosmia and the dysgeusia, because it might be an unrelated COVID-19 etiology. If there is none and there's persistence, then again, follow up in the primary care and referral to ENT. These are the tests suggested for dysgeusia and the other diagnostic tests. Now, for the headache, again, red flags must be asked, and then ask these patients to go to the ER. If none, ask for previous illnesses or pathology and deal with it. If none, visit to, after doing all the tests, then with all the results, we have to do differential diagnosis. This might be an unrelated COVID-19 etiology. If that persists, then we have an unexplained ongoing headache. And then ask for the most common causes of headaches, whether this is tension headache, migraine, or cluster headache. And this might be actually related to post-COVID-19 chronic headache. And if it's not, this is a chronic headache, follow up with the primary physician, and a referral to a neurology might be in place. Okay, for headache, these are the diagnostic tests and other diagnostic tests need to be done. For the digestive symptoms, again, you have to look at red flags, abdominal pain, rectorrhgia, palpable abdominal mass, weight loss of more than 5% or anemia, and then we send them to the emergency room. If none, again, ask for previous illnesses and deal with it accordingly. If none, you have to rule out other differentials on visit 2, see if this is post-COVID-19 complications or unrelated to COVID-19. And if that persists to 12 weeks, then you have an unexplained ongoing digestive symptoms, and follow up at the primary care, and then referral to a GI might again be done. These are the tests that need to be done and other diagnostic tests. Now, we have to remember that there are sequelae of long COVID, especially the cardiopulmonary side. So studies have reported that there are significant percentage of patients with abnormal results in their respiratory function, which may happen in around 54% of patients at the end of the first month, and fibrosis may persist at the 26% at 3 months, and maybe 50% in those patients who were admitted in the ICU. Pleural thickening may be present in 27%, and effusion might be present, although not really very common. Now, cardiac myocarditis is actually highest during the first 2 weeks. In fact, troponin levels may be seen in 40 to 80% of patients, even at the end of the second month. Abnormal cardiac MRI may be present in 78% of patients, while there are less pericardial effusions and cardiac tamponade. Now, we have heard a lot of post-COVID-19 thrombosis, although this is associated with coagulopathy, but long COVID sequelae of post-COVID-19 thrombosis is only around 3%. The other immune-mediated manifestations of long COVID may be arthritis, myositis, pancreatitis, and others. Emotional well-being and mental health deserves a special evaluation, okay? Because isolation actually leads to reduced physical activity and greater isolation, which may be particularly problematic, especially in elderly patients, because of reduced physical activity and potential increase in mental health problems such as anxiety and depression. Now, a study says that 36% of patients may have altered mental and cognitive questionnaire scores even at the end of the 3rd month, although there is actually no link between the severity of COVID-19 patients and the altered mental and cognitive status. Now, in that study, in that guideline, the working group actually think that there is more reason to consider that the emotional well-being and mental health of those patients may just be a reactive manifestation. That is because they have experienced a very highly traumatic situation. But they know that the impact on the quality of life is enormous, no? It may possibly impact with the other manifestations of long COVID-19. The role of primary care physicians is very vital in the care of long COVID-19 patients. Unlike specialists who deal mainly with the specific problem of a patient might have, the PCP or the primary care physician provides an integrated and comprehensive health care. So when faced with a patient with long COVID symptoms, the clinical practice guideline will guide us how to manage these cases holistically and with a multidisciplinary approach and empowerment of the affected patient groups in the end. There are some limitations of the study, however. So the lack of a scientifically accepted definition of what long COVID is, the limited currently available scientific evidence, the wide methodological differences among the few reported studies actually make it very difficult to assess the frequency of long COVID-19. There are studies on symptomatic COVID-19 patients that lasted 4 weeks, more than 4 weeks post-diagnosis, and they have widely differing methodologies also. And there is no overall figure that can be suggested, especially in those outpatients followed up in the primary care. So if there are no consensus, progress cannot be made on the definition of the variables that they need to measure. So people who develop the symptoms de novo once the acute infection is resolved also were included, like patients having fatigue, chronic pain, headache, and memory disturbances. Are these just psychological or social determinants, or are these direct etiopathogenetic link with SARS-CoV-2 infection? So there are still a lot of things we don't know, but soon, hopefully, there will be more studies that will come out that will be the basis of another clinical practice guideline in the future. So in summary, we have talked about COVID-19 infection in its prevention. We talked about the hierarchy of hazard control, and we specifically talked in detail the ventilation strategies. We emphasize the importance of the minimum public health safety protocols. And lastly, we have discussed long COVID clinical practice guidelines in primary care. These are some of the references that I used, and I would like to thank also Dr. Joel Sanchigel, from whom I got some of the slides presented here today. Thank you and good afternoon.
To talk about air quality and ventilation, an engineering challenge. Here is our next speaker.
Our speaker is a graduate of Bachelor of Science in Chemical Engineering from the Mapua Institute of Technology. Former Chief of the Environment Control Division of OSHC Dole. Officer in Charge and Deputy Executive Director of the OSHC Dole. Accredited OSH Consultant. International Labor Organization Consultant and a very good training officer of the basic course of PCOM. Let us all welcome Engineer Nelia G. Grandillos.
Good afternoon and thank you to PCOM Laguna Chapter for inviting me to be part of the 4th postgraduate course. Magandang hapon po. My topic is air quality and ventilation, a threat to respiratory system. We know that ventilation is essential in maintaining the health of an individual. Amidst the pandemic, the need for adequacy of ventilation was given more emphasis in preventing transmission of COVID-19. The safety seal issued by the government ensures the public entering a facility such as malls, restaurants, and companies that they are compliant to minimum health standards, including ventilation. So the outline of my presentation will cover the importance of ventilation. What are these air contaminants, specifically in indoor environment? How do we assess ventilation? What are the control measures that will, for us to attain adequate ventilation? And what are the DOLE standards and guidelines on ventilation? So why is ventilation important? This will prevent respiratory diseases through elimination of hazardous air contaminants reaching the breathing zone. So first and foremost is to prevent the inhalation of these air contaminants. Second is to renew the air in an enclosed area, thus diluting the air contaminants to acceptable levels. This means that concentrations of these contaminants should be brought down within the threshold limit values. And lastly, to ensure the conditions of thermal comfort by controlling temperature and humidity, thus preventing fire and explosion. Now, ventilation can be simply explained by two generic types of the system. The supply system that furnishes fresh air in an area, and the exhaust system that removes the contaminants generated by an operation or by the occupants themselves. It can be done through natural means, such as opening more windows and doors, or by mechanical means, such as through the supply and exhaust fans and HVAC, or the heating, ventilation, and air conditioning system. Now, a study by the National Institute of Environmental Health and Sciences showed the following respiratory diseases attributed to the exposure to indoor air pollutants. 34% resulted to stroke. 26% ischemic heart disease. 22% COPD or the chronic obstructive pulmonary disease. 12% attributed to acute lower respiratory infections in children. And lastly, 6% resulted to lung cancer. Air pollution, all forms of which is responsible for more than 6.5 million deaths each year globally, and a number that has increased over the past 2 decades. This slide shows that the common air contaminants based on the particle size. It may be visible through the microscope or to the human eye. And the HEPA filter with capacity to filter sizes of 0.3 microns in size. Air pollution is a mix of hazardous substances coming from industries with its complexity of processes and an increasing number of compounds, many of which are highly toxic. This air pollution may come from natural sources as well, from human-made, such as often caused by people, and gases like methane from decomposing organic matter. So what are the factors to consider for adequacy of ventilation? Let's start with the airflow, which is the general direction should be from cleaner air to less clean air, making sure that the outdoor air intakes are clear and not drawing air from a parking lot, the traffic side of the building, or near smoking areas or loading docks, and avoid moving contaminated air from person to person. The second factor is the ACH, or the air changes per hour. It is the ratio of the ventilation rate to the room volume. It is important to maintain as much outside air and or sufficiently filtered, recirculated air as possible to achieve the goal of greater than 6 ACH, or air changes per hour. Next is the HVAC. This refers to the equipment and distribution used for heating, ventilating, cooling, humidifying, dehumidifying, and cleansing of air for a building. Through the HVAC, the amount of outside air can be increased and the filter efficiency as much as the system can handle, as well as possible modifications to airflow patterns to decrease the risk of airborne transmission. HVAC is managed by the mechanical engineers or your engineering and facilities engineers. Fourth is the positive pressure conditions. ASHRAE and ACGIH recommend positive pressurization between 0.002 inches and 0.005 inches water versus outdoor supplied to the air in the building. If the amount of replacement air supplied to the building is lower than the amount of air exhausted, the pressure in the building now will be lower than atmospheric. And this condition is negative pressure. So you understand that between the positive and the negative pressure, but ASHRAE and ACGIH recommend the positive pressurization. And lastly, increase the filtration efficiency of the system to a minimum efficiency reporting value, or MERV 13, or as high as the filter racks or fan pressure drop will allow. So it all depends on your system. So air cleaning device such as filters remove contaminants from an air or gas stream through considering the quantity and characteristics of the contaminants to be removed. Okay, so these are all the factors for us to consider for ventilation to be adequate. So, for guidance, we refer to standards and guidelines in the provision of ventilation. We have the ventilation rates for healthcare facilities, residential buildings, and vehicles from ASHRAE. We have the Philippine Mechanical Engineering Code. We have the ACGIH on this right, upper right. American Standards of Safety Engineers on the lower right, and our very own Occupational Safety and Health Standards, DOLE Philippines. In order to comply with these ventilation standards, measurement of ventilation and air quality must be conducted with the use of calibrated industrial hygiene equipment. Smoke tubes for air visualization to determine the direction of the air. The thermometer to measure temperature and air velocity in degrees centigrade and meter per second. Balometer to measure the air volume or flow rate in meter per second or cubic feet per minute. Psychrometer to measure relative humidity in percent. And laser distance steel tape to measure the length to compute for the area and volume of the openings and room, and the gas monitor to measure the different gases potentially present in the enclosed area, and the Dole DO224 mentioned that carbon dioxide is a surrogate indicator for assessing indoor air quality. In reference to Occupational Safety and Health Standards, Rule 1076 on the general ventilation, Rule 1076 sets the air supply air movement standards for air ventilation, general ventilation. Clean, fresh air shall be supplied to enclosed workplaces at an average rate of not less than 20 to 40 cubic meters an hour per worker. 2. Air changes per hour should be 4 for sedentary workers and 8 for active workers. And 3. Air movement requirement for rainy season is 0.25 meter per second and 0.75 meter per second for summer season. For non-aircon air spaces, based on Dole DO224, guidelines on ventilation, increase the outdoor air supply to 100% if possible, or to the maximum allowed by the capabilities of the ventilation system. Maintain between 6 to 12 air changes per hour, but take note that 6 to 12 is recommended for prevention of COVID-19 because in our OSH standards, 4 to 8 air changes is required for industrial workplaces. So there's the difference. And exhaust fans should be continuously open as much as possible. And for the air-conditioned workplaces based on Dole DO224, here are the guidelines. We have to increase the filtration efficiency of the system at MERV 13 or select the highest MERV rated filter that your system can support. You have to consider the capacity of your HVAC system. It is recommended that your HVAC or the mechanical engineers or their HVAC unit manufacturer to determine an optimal filtration strategy. Next, the airflow direction must be considered. Fans should be positioned so that air does not pass from one worker to another. Make sure that your relative humidity is kept at 40 to 60% range for infectious aerosol control. Make sure that ventilation system is performing as designed and is properly maintained, and it is done by our engineering and facilities personnel, and keep louvers of local aircon unit upward in an upward position. So these guidelines, you can find these guidelines in Dole DO224. But there are a lot of questions, frequently asked questions, one of which is on the ionizers. Marami pong nagtatanong, is these ionizers are really effective in the control of COVID-19. So, meron pong stand ang ACGIH and ASHRAE. They're still considering that this is an emerging technology and there are not sufficient results to develop a position. So if your company is planning to incorporate this equipment in your facility, make sure that the equipment meets the standard certification for zero ozone emissions for air cleaners to determine if it does not negatively impact on human health. You know very well that there's an issue of ozone generation using the ionizers affecting human health. So, to conclude this session on air quality and ventilation, a threat to respiratory system, first, we have to increase the amount of outside air and the filter efficiency as much as the system can handle, as well as possible modification to airflow patterns are all recommended to decrease the risk of airborne transmission. Airflow direction must always be considered. Fans should be positioned so that air does not pass from one worker to another. And continued ventilation of occupied spaces is best practice for protection. And these are all the guidelines. And who are the people who can help us? It is the mechanical engineers, it is the industrial hygienists, it is the HVAC manufacturer, but as OSH professional should be on top and responsible in ensuring the adequacy of ventilation. Thank you very much for listening. I would like to thank the PCOM Laguna, headed with the leadership of the President Dr. Angie and President Ria, the National President of PCOM, and all my PCOM family. Thank you very much for having me in this postgrad course. I'm very pleased to inform that after my retirement in OSHC, I continue my advocacy in OSH, being an ILO OSH consultant and having WEMTEX, our family enterprise, as an accredited safety training org and an accredited WEM provider at your service. Maraming salamat po. And I open the floor to your questions. Thank you very much.
Thank you very much. Thank you very much po, Dr. Cynthia, and thank you very much also, Engineer Nay. I familiar po ko to both of our distinguished speakers. So the floor is now open for our question and answer. So let me break the ice. So I'll not repeat the questions already answered on the chat box. So for Dr. Cynthia, are there pneumoconiosis studies being conducted in the Philippines, specifically in relation to silicosis or silicotuberculosis? Because in the workplace setting, there are still concerns of TB aside from COVID. Can you share po your thoughts on the pneumoconiosis in the workplace?
This is actually beside the scope of my lecture, no? But yes, that's a very important concern. And until now, we are seeing a lot of that. And this is actually a problem in the workplace because we still see materials, no, around that are being used that can cause silicosis that's also related with tuberculosis. So the treatment, no, and management actually is already in place, no, and I don't exactly know how many are current currently affected by silicosis, but very recently there was just a webinar on that. I'm just not aware how common it is at this time. But the management and treatment of how do we go about the treatment for silicosis is already in place.
Thank you po, Doktora. Just a follow-up, there's a question from the chat box. Can you comment daw po on the use of diffusers? Medyo uso nga to, no? Diffusers with essential oils in relation to the respiratory status of patients/employees.
I think baka Engineer Grandillos can answer that better, no? Because it has something to do with indoor air.
Sige po, I'll transfer to Engineer Ne. Your comments, please.
Yes, thank you very much for the question, and I would like to thank Dr. Talla for sharing with me your expertise in this air quality and ventilation. Thank you po. With regards to your question, I have not encountered any recommendations from the experts such as the ASHRAE and the ACGAH on the use of essential oils. Wala pa po akong nabasang ganyan, pero I believe that I don't know what will be the purpose of using essential oil. Is it the scent or you want to sleep well? So, but with regards to removing the contaminants in the air, I think it will not solve the problem. That's it. Thank you very much.
Maybe if I can just add a little, no? That depends probably on how foul or how strong the smell is, no? Especially so for, let's say, asthmatic patients, no? They may be an irritant and may have an exacerbation of asthma.
Thank you po, Dr. Cynthia. Engineer Nate, siguro I remember Engineer Nate during the panel interview so well. Engineer Nate, how do you manage po ba sick building syndrome from the context of indoor air quality? Especially there are companies that are, let's say, relatively old. How can they fix their indoor air quality, especially with using old buildings in relation to SPS?
Yes, thank you. And that's a very good question with regards to indoor air quality. You know, for old buildings, the issue there are the molds. Ang dami pong molds. Ang ginagawa nila, pinipinturahan lang nila to parang facelift the surfaces, but the molds, especially in the ceiling, ang dami po niyan. Marami na pong studies, even in hospitals, na the surfaces are painted very well, but inside it, there are molds. So that's one issue for the sick building syndrome. And of course, there's a lot of factors, as I've discussed, in ensuring that there is good air quality in the room. Especially if there are no air changes in the room, definitely the air contaminants stay inside the room. So malaking factor po if you consult your facilities or those knowledgeable in ventilation system, that will really help. Hindi po isang solution lang po yan, but everything else as I've discussed, all of this filtration, air cleaning device, the air changes, the air direction, all of them should be considered to make sure that ventilation is good inside the enclosed room, especially for old buildings.
Thank you very much po, Engineer Ney. Siguro I would relate it from the transitioning from the industrial hygiene side going to the medical surveillance side and biological monitoring. Dr. Cynthia, what would you advise OH physicians and OH nurses on are there medical monitoring tools that we could use, especially if, for example, merong mga molds, may mga certain microorganisms that we could see in the environment that are not readily seen on chest X-ray? Are there other forms of monitoring tools that OH professionals can order?
I think that depends on how susceptible or how sensitive the employee is, no? So if you have an employee that comes to you with cough, no, then you might want to do more tests, no? Because these are the patients who may have allergies or you may have asthma that you do not know presenting as cough, no? So X-ray will not probably be of help, but spirometry, like is done in some other companies, no? It helps in identifying who are the patients who may be susceptible to this. But of course, as I agree with Engineer Ney, no, it will always be helpful that you have a very good clean indoor air. There's no place for molds or dust or anything like that.
Thank you po, Dr. Cynthia. Engineer Ney, there are, of course, workplace settings sa company. Di ba, merong Rule 1070 on WEM, we have the standards. To your expert knowledge po, is there WEM or indoor air quality requirements or compliances sa healthcare and hospital setting?
Thank you for your question. Hindi ko nakita sa chat box yan, ha? Siguro galing sa iyo yan. Dr. Gerard. Yes, yung nasa OSH standards po, these standards are applicable to industrial settings, sa mga industriya po ito. So, the DOLE po leaves it to the DOH with regards to the healthcare facilities. Kasi po, specialized ang hospital, ang mga clinics. So yung OSH standards po, as I've mentioned, even in the air changes per hour, iba yung sa industrial, iba yung for prevention of infectious diseases. Mas stringent po yung sa prevention of transmission of these infectious diseases. So I may say that hindi po, for us in the DOLE, for us to be able to evaluate, especially the WEM providers, for us to be able to evaluate those contaminants that are not present, where the TLBs are not present in the OSH standards, we refer to international guidelines. For purposes lang po na maka-evaluate kami. Pero as I've said, yung nasa OSH standards po are talagang for the industrial settings. Yung nag-generate ng a lot of chemicals in the workplace and all the health hazards in the workplace.
Thank you po, Engineer. Follow up, Engineer Ney, sorry. Ito, nasa chat box na po to. Yung regarding daw po sa essential oils and oil diffusers could be compared to chemical burning. This is from idol Dr. Jan. So what could be the possible residual gases formed out of that chemical process?
Okay. Thank you, idol Jan. Idol Jan pala. Sige, Doc Jan. Alam niyo naman po, ang base ng essential oils are organic solvents. Actually, ang iisip ko dyan, because of the scent, that may really help. Pero hindi ko natin makompare yan sa chemical burning. Iba yung chemical burning. It is where there is, of course, burning, but it's not burning. So, ang issue po dito sa essential oils are the organic solvents. As mentioned ni Dr. Cynthia, ay baka naman yung mga asthmatic, may mga allergies, especially for scents na talagang sobrang bango, baka it may not really help. So if depending on your purpose, ano ba ang purpose mo of using essential oils? Is it to remove COVID, or is it to reduce the contaminants? So what will be the purpose? Depende po kung ano yung objective or purpose of using the essential oils. But definitely an issue on organic solvents.
Engineer Ney, may follow-up po. What mechanisms can be adopted in the company/industrial setting, balancing thermal comfort and elimination of biological contaminants? I believe siguro this is in the context of heat stress, but of course, if mainit yung area, bumibilis din yung metabolism ng microorganism. So, can you comment po on how to effectively manage heat stress vis-a-vis with the microbiological contaminants sa workplace?
Thank you very much for the very good question. Alam niyo po, laging may contradicting issue yan, especially dun sa green building, na they want to reduce energy conservation. bawasan ang paggamit ng enerhiya to the point na nagsasuffer ang health and safety. It's not only the thermal comfort, aircon, but also especially for illumination. They don't want to lit the stairs, those mga corridors. Wala na silang ilaw doon because of aircon. But it suffers, the health and safety is an issue there, especially for aircon. Gusto nilang bawasan yung energy, yung electricity consumption, but to the point na nawawala na po ang thermal comfort. So I may answer that we have to balance energy and health and safety. Kailangan po we make sure our priority are the people, yung ating human health, more than the energy. Of course, we need energy conservation, but more than that is our human health. Yun lang po. Thank you.
Thank you po, Engineer Nay. So at this point, I'll reserve one last question. I've been primed by the hosts. So, Dr. Cynthia, can you what advice can you give us, especially po yung employees and patients na may pets or may mga roaming around na pets both in the company and hospital setting triggering respiratory symptoms? Ano po kayang magandang gawin for that situation?
That's a very nice question. In fact, that's a challenge to us pulmonologists, no? Especially if we're dealing with asthma and allergies, no? And then there are some patients who actually have recurrent asthma just because they cannot get rid of their pets. Because we all know that if you're dealing with allergy, you have to get them out of the allergy. So maybe it's important to educate these patients, no, first and foremost, that they have to get rid of the allergens and the other triggers, no? So ganun yon, anong gusto niya? Yung pet niya, pero lagi siyang may sakit, or get it out of her system and they will get better. Most of them, when you get to talk to them, they will understand. I have one patient like that. Almost every month she's in my clinic because they are breeding pala, no, dogs. So sasabihin nila, Doktora, meron namang hypoallergenic. But even then, if you go to the basic principle of treating allergic conditions, first and foremost is to get you out of the allergen and the triggers. So education is really a very, very important part of treatment, no? But just the same, kung meron pa rin, let's say they got out of it, they got rid of it, then you have to treat, no, depending on how the severity of the illness is, no? But sa akin, bottom line, it will still be education.
Thank you po, Dr. Cynthia. To add then, because some actually have a standby Montelukast, can you comment on the long-term use of Montelukast and levocetirizine? Kasi in the
yeah, okay. So if we go through the guideline of the management, are we specifically talking about asthma?
Asthma and allergic rhinitis. Some employees tend to self-medicate and of course difficulty.
First and foremost, Montelukast is not a very it's not fast-acting medication. It's not actually in the reliever list of medications, no? And if you go through the GINA guideline, no, the first treatment will always be inhaled corticosteroids. Diba? Hindi yung ano lang siya, option lang siya. So if we were gonna treat these patients having mild asthma, no, first and foremost, the mainstay or the cornerstone of treatment will always be inhaled corticosteroids and not Montelukast. Okay, so before you get to have the effect of Montelukast, it will take a while, no, and these patients need to be returning back to their lung function soonest. Okay. So Montelukast doesn't have a role for PRN use. No, there are no studies to show that.
Thank you very much po, Dr. Cynthia. So sayang, madami pang tanong, pero in the interest of time, last question to Engineer Nate. Can you comment po on the burning question tong purifier, no, tsaka mga oil? Can you comment daw po on the use of portable air purifiers, mga necklaces, from the engineer's perspective po?
Naku, napaka-controversial talaga yan, yung mga necklaces na yan. Siguro, I will not recommend. Kasi, of course, how much volume lang, kung nakalagay lang dyan a small piece in front of your breathing zone, it will not really help. So, personally, hindi ko po ma-recommend yan necklaces, but for air purifiers installed in your system, in the HVAC system, that is very important. The air cleaning device that is installed in your HVAC system, especially ang COVID-19 po is recommending a MERV 13 or higher if it can accommodate such filtration capacity. And of course, yung ionizers naman, napaka-controversial din yan. Ang ionizers naman po, ang issue dyan is the generation of the ozone. You know very well, ozone is a toxic gas. So, baka gusto nating to kill the virus through ozonization, but affecting our human health, syempre, we go for the less ozone in the air. So, siguro hindi ko rin po ma-recommend ang ionizers. Yun lang po. Thank you.
Ako, engineer, meron po akong isang question lang. Last, short lang, short.
Sige po.
But for air purifiers in a room, di ba parang there are purifiers that are effective only for this size of the room?
Yes,
Will that, okay, let's say in the clinic po, no? Especially if the clinic doesn't have very good ventilation, no window, no? But we have the doors that are kept open. But inside the room, we just have the air purifiers. Will that be okay?
Of course, ang air purifier po is a air cleaning device. It will really help. Pero ang efficiency of these air purifiers will depend on the size of the room. It will depend on the occupants in the room. So, yung kakayahan po, capacity of the air purifier will depend on different factors that we have to consider, as I've said. Pero, Doktora, the air purifier can really help. But as to how much efficiency it will give us, depende na po yan sa mga factors that I've mentioned.
Thank you, Engineer.
Thank you po.
Thank you po, Dr. Cynthia. Thank you, Engineer, for your kind answers and for gracing our postgraduate course. So thank you very much po and happy weekend. I'll turn the floor over to our hosts.
Thank you very much.
Thank you very much.
Oh.